Fellow of the European Society of Cardiology. Dr. BRM Aryo Suryo Kuncoro, spesialis jantung pembuluh darah konsultan, Fellow of Indonesian Heart Association, Fellow of ASEAN Federation of Cardiology. Dr. Celi Anantarya, spesialis jantung pembuluh darah konsultan, Fellow of Indonesian Heart Association, Fellow of ASEAN Federation of Cardiology. Dan kepada perwakilan PT Daria Varia Laboratoria, Bapak Bob Barrera selaku PSG Director, Bapak Dedi Septiadi selaku Head of Marketing PSG, Bapak Zainal Arifin Sinaga selaku Head of Operation 1 PSG, Ibu Riyadini Triwahyuni selaku Group Product Manager PSG. Untuk membuka acara pada hari ini, kami persilakan kepada Dr. Renan Sukmawan, spesialis jantung pembuluh darah konsultan PhD, Magister Administrasi Rumah Sakit, Fellow of Indonesian Heart Association, Fellow of the American College of Cardiology, selaku Ketua Kolegium Jantung dan Pembuluh Darah, Perhimpunan Dokter Spesialis Kardiovaskular Indonesia, untuk menyampaikan kata sambutan. Kepada Dr. Renan, waktu dan tempat kami persilakan.
Baik. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera untuk kita semua. Apakah suara saya cukup terdengar?
Terdengar, Dok.
Baik. Alright. Since this is an international webinar series, let me talk in English. A very warm good afternoon, my colleagues, ladies and gentlemen. It's a great pleasure for me to have you all join this program. This program is held under collaboration between Department of Cardiology and Cardiovascular Medicine, Faculty of Medicine, Universitas Indonesia, at Harapan Kita National Cardiovascular Center in Jakarta, and also our department also belongs part also to Hospital of University of Indonesia. So University of Indonesia Hospital, and also with collaboration, great collaboration so far with Department of Cardiology, Padova University in Italy. This program brought to you under great support from Daria Varia. Again, thank you for this great program, Daria Varia, who always support us. I believe not only in cardiovascular medicine, but also in other fields. There are lots of contribution made by Daria to enable this kind of program. As you know, last time we have program on cardiac auscultation. Today we have program with Padua University on cardiovascular imaging, but yet actually it's not direct to Daria Varia's product, but you all of us can see how Daria can support us to improve, to advance the understanding, our understanding on the cardiovascular medicine. I would also to thank you for Professor Eliseto, always provide a great collaboration with us, and also with Indonesian Heart Association, and with other all subjects, all fields, all colleagues that come together to enable this kind of program. My colleagues, ladies and gentlemen, as you know, cardiovascular imaging is an integrated part of cardiovascular medical science all over the world, especially with the advanced knowledge on cardiac CT and cardiac MRI. And today we will learn how these modalities, along with echocardiography, in the treating, in diagnosis and treating the patient with hypertension and heart failure. As you know, we are in the midst of pandemic, yet we still have to provide the best care we have to our patient, because patient with cardiovascular disease among those with high risk comorbid to get severe COVID-19 when they get infected. That's why today's program is very important for us to let us learn let you know how this modality can help us, can assist us to make better care of our patient. And we will learn how that happens in Europe with Professor Eliseto, and also what we have here in Indonesia in our cardiac center all over Indonesia. Again, thank you very much for support of Daria, and also for everybody who joined this program. And have a great webinar. Please feel free uh, to post your question even in Bahasa Indonesia, because we learned today many things. So any question would be welcome. Again, thank you everybody. Have a nice program. Assalamualaikum warahmatullahi wabarakatuh.
Terima kasih kepada Dr. Renan atas kata sambutannya. Selanjutnya kami mengundang Ibu Triadini Triwayuni selaku Grup Product Manager PT Daria Varia Laboratoria untuk menyampaikan kata sambutan. Kepada Ibu Triadini, waktu dan tempat kami persilakan.
Terima kasih, Kevin. Thank you, Dr. Renan, for the great introduction. And on behalf of Daria Varia Management, we would like to say thank you very much for the opportunity to allow us contribute in the session. Hopefully, this webinar series, this is the first series from our fourth series. We can get more knowledge and give opportunity Daria to contribute to Indonesian health. And I would like to say thank you to our speakers today, Prof. Ileseto, Dr. Aryo Suryo Kuncoro, SPJP, PH FACC, and moderator Dr. Sally. And we all hope all the professor, doctors, and all the attendants will enjoy this webinar. So on behalf of the management, we would like to say thank you and have enjoyed the virtual webinar with Padua University.
Terima kasih kepada Ibu Triadini atas kata sambutannya. Selanjutnya memasuki scientific session, kami mengundang moderator pada sesi kali ini, Dr. Celi Antaria, spesialis jantung pembuluh darah konsultan, yang saat ini menjabat sebagai pengajar di Fakultas Kedokteran Universitas Indonesia, konsultan kardiologis divisi non-invasive diagnosis, dan kardiovaskular imaging Rumah Sakit Pusat Jantung Nasional Harapan Kita. Kepada Dr. Celi, waktu dan tempat kami persilahkan.
Good afternoon. Thank you, Mas Kevin, for the kind introduction. And it's an honor to be part of this exciting webinar today. Selamat siang, selamat datang kepada Bapak, Ibu, Profesor, Dokter, dan Dokter yang sudah bergabung pada acara International Webinar Series on Cardiovascular Medicine hari ini. Dan semoga selalu diberi kesehatan. Our International Webinar Series on Cardiovascular Medicine is presented by Indonesian Cardiovascular Foundation, YKVI, in collaboration with Department of Cardiology and Vascular Medicine, Universitas Indonesia, National Cardiovascular Center Harapan Kita, and Department of Cardiology, Padua University, Italy, and Daria Varia Laboratoria. Thank you for the support. And I would like to welcome everybody today on webinar of multimodality cardiovascular imaging on hypertension and heart failure. And as we know, as cardiologists, we have been doing cardiovascular imaging in our daily practice. And this webinar will hopefully set a standard on how we see and take care of our patients better. So before we get started, let me go through some housekeeping to ensure that this webinar runs well. So firstly, it is a 2-hour sessions in which we will have 3 sessions of 2-minute talks each, and there will be a question and answer session after all talks finished. And secondly, if anybody wish to ask the presenters a question, please click on the raise hand icon on the bottom of the screen, or you can type your questions. I would now like to welcome our first speaker, Professor Sabino Iliseto, MD, FACC, FASC. Thank you, Prof, for your attendance, and very nice to meet you again. Prof. Iliseto is a full professor of cardiology, director of the School of Cardiology, director of cardiac, thoracic, and vascular sciences, Department in University of Padua Medical School, Italy, Chief of Cardiology Division, University Civil Hospital in Padua, Italy. And Professor Ilseto would like to give a talk on advances in the evaluation of hypertrophy and heart failure, role of cardiac MRI. Prof. Iliseto, time is yours. Thank you.
So, uh, okay, first of all, I thank you for the invitation. It's always a pleasure to interact with good friends from Indonesia. In these years, there's been an increasing depth of our relationship, and I'm happy to say hello to Dr. Renan and other friends in Indonesia. So, as Dr. Renner was pointing out, we are in a special moment in of the humanity, because the pandemic is something that we could not predict. It's something that we don't know exactly how to manage, and I think that everywhere in the world there is the feeling that we don't really understand how many medicine will be in the future. So, from my point of view, since I have to teach cardiology to the fellows, uh, many things will change. The traditional approach to cardiology, as well the traditional approach to all the specialty of medicine, will be affected uh, positively, I should say, because we have to be more and more um, we have to have more and more concern about the fact that we have to be able to better stratify patients in terms of prognosis, better understand of the disease, in order to optimize our treatment, in order to maximize the efficacy of what we do, since we have something more to do because of the pandemic. So this concept well applied to cardiology, well applied to new cardiac imaging techniques. And in this first talk, I shall give you an overview of why cardiac MRI is a new window on the heart in the context, for example, of hypertrophy and heart failure. And not only in this, but now we should spend time on hypertrophy and heart failure. So this is a very nice picture of a patient with a dilated cardiomyopathy of diabetic origin. This is a four-chamber view captured by magnetic resonance imaging. And as you can see, is a fantastic and detailed imaging of the heart. You can appreciate the left atrium, the right atrium, the left and the right ventricle, and very, very, very well the muscle as well, for example, the papillary muscle. So this is a luxury echocardiography, but the real potential of cardiac MRI is not the fact that can be considered a luxury echocardiography, but is really, in my opinion, a sort of cardiac pathology in vivo. And this is due to the fact that the big potential of cardiac MRI are due to the capability of the technique to explore the tissue within the myocardium and to differentiate different characteristics, as we shall see, but also because during this year, it has been more and more clear that the contrast enhancement through gadolinium is a very sophisticated modality that underlines the presence of extra myocyte tissue that is abnormal in its entity because gadolinium deposited in this area. And so when we have gadolinium injected and we see gadolinium in the myocardium, something wrong exists. Of course, something wrong has to be interpreted in the light of the clinical context. These experimental data show you how myocardial infarction can be depicted. In the upper panel here, red and yellow, you have a piece of an experimental myocardial infarction obtained in an animal model. And you will see that the yellow means infarct, red means good myocardium. In the lower panel, you will see the same slides imaged by cardiac MRI, and in white you have gadolinium, in gray you have muscle, and so you can appreciate how similar the two images are, meaning that the injection of gadolinium has been able to identify presence, localization, and extent of scar. So this is a great potential. So how this can apply to the two topics that have been assigned to me in this first talk that is concentrated on hypertrophy and heart failure. So how cardiac MRI can be useful in our patient with hypertrophy, for example. And of course, hypertrophy is something that is as specific of a disease because we can encounter hypertrophy in many situations. But this gives you, for example, an idea of how detailed can be the description of hypertrophy. This is a short axis view. You can see how nicely depicted is the extent of thickness of the myocardium. Here is a four-chamber view. And in the moving images, you can also appreciate that there is an important obstruction of the left ventricle that involve the mid and the distal part of the myocardium of the left ventricle with the apex that is not contracted at all. So a great potential in terms of depicting the extent of hypertrophy better than other cardiac imaging techniques. However, cardiac MRI should not be used for this purpose because echocardiography, for example, is more than enough to depict hypertrophy. But if we go to some specific hypertrophy, like for example in hypertrophic cardiomyopathy, then you can appreciate again the big potential in depicting the extent of hypertrophy, as in this case, in which a nice comparison between echocardiography and cardiac MRI is outlined, and it shows how we can have very nice depicting with traditional echocardiography. But what cardiac MRI can give us is something more. Not only the description of hypertrophy or cardiac structure, like for example papillary muscle, this small aneurysm in the posterior wall, but the big advantage is here depicted, is the presence, as I've shown you, of gadolinium. Gadolinium is these white dots here in the black-gray myocardium. So in this kind of sequence, and let me tell you that for cardiac MRI people, the sequence is the setting of the equipment that is designed in order to maximize the detection of a kind of structure. There are sequence for water, edema, sequence for fat, sequence for myocardium, sequence for scar. And here you can see that in these patients with hypertrophic cardiomyopathy, there are many areas with the white gadolinium that correspond to this scar in this anatomic specimen. So the big issue is what does it mean? What does it imply? Is this a big advantage? So let's go, for example, in this specific case. In this specific case with hypertrophic cardiomyopathy, you have two different settings. This is very, very similar to echocardiography on the left panel. And you can see here the aortic root, the anterior mitral leaflet, the posterior leaflet, the interventricular septum, the posterolateral wall, the left atrium. The interventricular septum is huge, is very important hypertrophy in the upper third with an obstruction of the mid-ventricular level. So again, this is a luxury echocardiography. But if we move on the right, we have another potential cardiac MRI that is called first pass. First pass means that a contrast agent is injected. You can see here a short axis of the left ventricle. And when the contrast agent is injected, the muscle become white. White because there is the contrast agent that enters in the myocardium. But as you can see, sorry for that, as you can see, okay, here there is this triangle at 10 o'clock 10 o'clock position. That means that this part of the myocardium has been not perfused during injection. This is the counterpart of other sequence like this one, in which you return to see in the same short axis white. So what does it mean, this white in hypertrophic cardiomyopathy? The presence of scar. And this is a very common place where a scar can be detected, is the junction between the interventricular septum and the anterior wall. And when scar is detected, the risk of arrhythmias in that specific patient strongly increase. In fact, it has been shown that in patients with scar, the risk of sudden cardiac death is strongly increased if compared to other patients with hypertrophy without this specific sign. So one potential in this context is that of identify patients with huge hypertrophy and a higher risk of sudden cardiac death, and therefore these are more prone to be a candidate of implantation of implantable cardiac defibrillator. Another area very common nowadays of hypertrophy is that of aortic stenosis. Again, cardiac MRI is a luxury echocardiography. You can see here a nice long axis of the left ventricle in this patient with poor contractility and severe aortic stenosis. It is being shown in here on the right, and you can see how is narrow the orifice of this very nicely depicted aortic valve. So which is the advantage of cardiac MRI in the context of aortic stenosis? Certainly not to identify the gradient, because echocardiography is still the superior method. In the upper left, you can see a very nice Doppler tracing of aortic stenosis. Certainly not to better describe the aortic leaflet that are very, very well depicted in these nice echocardiogram that show hypertrophy, aortic stenosis, and gradient. But again, it returns the potential to show this white area within the myocardium. That is a short axis. As you can see, the muscle gray is not homogeneously gray, but there are these white dots. And these white dots again represent scar. So the potential of cardiac MRI in aortic stenosis hypertrophy are of two sources. The first is to understand, like echocardiography, but more precisely, because cardiac MRI has a better definition, is the left ventricular mass is appropriately increased or not according to the presence of aortic stenosis. And the presence or presence of appropriate hypertrophy will imply prognosis, as this graph shows. Those with appropriate left ventricular mass have a better outcome if compared to those that have not. But again, the big advantage is the presence of scar, the capability to detect scar. This is a little bit complicated slide, so I should spend 1 minute to explain. This is a series of a prestigious series of more than 600 patients with severe aortic stenosis. These patients were submitted to cardiac MRI, And then patients were divided in those having or not having gadolinium. That, in other words, means with the absence or presence of scar. So red is gadolinium present, black is gadolinium absent. That means scar present, scar absent. And as you can see, in all patients, those that were submitted to surgical aortic valve replacement, or those that were submitted to TAVI replacement, the presence of gadolinium identified those that had a worse prognosis in the follow-up, meaning again that the potential of cardiac MRI is in the detection on those patients that are higher risk independently from the entity of hypertrophy, just because within hypertrophy there is a scar that is an indicator of poor prognosis because of the high risk of severe arrhythmias. Cardiac amyloidosis in another entity that is characterized, as you can see, by higher degree of thickness. Here you have this very nice example, hypertrophy, very well distributed, and a good diagnosis can be done if we have hypertrophy and at the same time low voltage electrocardiography. And these are the corresponding images of Doppler tracing that is very useful, is more useful than cardiac MRI to identify, for example, diastolic dysfunction. So the question would be, but where is the advantage of cardiac MRI in a patient with amyloidosis if the main potential are, as I show you, the entity of thickness or other situation that cannot be detected so nicely like echo. Again, the big advantage is in the tissue exploration. And here you have another a little bit complicated slides that explain how a special sequence, again, I don't go into the detail of the sequence because this is something that is very interesting for radiologists, but for us, cardiology, we are not involved in performing cardiac MRI, we need to know that there are sequence, that means setting, that are specific for amyloidosis. And here you see that this sequence give higher signal in those with amyloidosis, meaning that there is a potential in amyloidosis for cardiac MRI to do and to perform a good diagnosis. Another form of hypertrophy is the physiological hypertrophy of athletes. We have given a lot of attention to this important chapter of cardiology in Padova because some of my colleagues pay a lot of attention to sport cardiology, and we are following a large number of people, athletes with hypertrophy. And what we have discovered is again that cardiac MRI is not simply useful to detect the entity of hypertrophy, because again, in my opinion, echocardiography is excellent for this purpose. We have not to ask anything more. But again, cardiac MRI is capable to identify, like in this patient, this was a marathon runner, white, that means scar, and we have found that in some patients, in some athletes in which severe arrhythmias were present, scar was detectable in the epicardial layer, something that is just the opposite of what is found in myocarditis, in which scar is found in the endocardial layer. And so we have explored a large series of cases like this one, in which there was also an abnormal electrocardiogram. And we have found that in competitive athletes, those with arrhythmias and gadolinium have a different outcome if compared to those without gadolinium, without scar, meaning that the present absence of scar even in athletes, make a difference in terms of outcome. So hypertrophy is something that needs to be furtherly explored if we think that in a patient there is a risk of arrhythmias, severe arrhythmias, risk of sudden death, regardless of the kind of hypertrophy. This is the big advantage of cardiac MRI. For heart failure, again, we have a luxury echocardiography. I like to use this term. We can have different slices of the heart from the aortic root to the left ventricular apex with a great detail. And so we are able to explore morphology, volume, thickness better than any other techniques. But it's not enough, in my opinion, to perform cardiac MRI because echocardiography is much more efficient in terms of cost effectiveness. It costs less, it's much available, can be done almost everywhere. The big advantage for cardiac MRI, again, is tissue exploration. And we have found, this is a paper from my group, that the presence of myocardial fibrosis, detected by cardiac resonance, in non-ischemic dilated cardiomyopathy is a great indicator of prognosis. These are example of patients with dilated cardiomyopathy. And for example, you can see very nicely here, white in the upper part, white here, big extent of white, but white with gadolinium means scar. And not surprising, these are those that have severe arrhythmias. And these are the data from the study in which we have shown that in patients with non-ischemic dilated cardiomyopathy, the absence or presence of late gadolinium enhanced LGE, that means absence or presence of scar, is a powerful discriminator of outcome in the follow-up. So my colleagues from Indonesia, I think that I want to address a concept that I hope that will remain clear in your mind, is that a cardiac MRI is extremely useful in patients with hypertrophy at heart failure, not because it substitutes echocardiography, because this is not the case, but because it allows accurate exploration of myocardial tissue. Again, is a sort of cardiac pathology in vivo. And this information is useful for better understanding the source, the etiopathogenesis of the disease, but more than anything else for the prognosis stratification, to identify those that with hypertrophy, independently from the reason of hypertrophy, um, aortic stenosis, hypertension, amyloidosis, or heart failure, ischemic, non-ischemic cardiomyopathy, independently from its pathogenesis, we can identify those that have a poor prognosis and risk of sudden cardiac death. I thank you very much for your attention.
Thank you, Prof. Iliseto. Very nice presentation, and thank you for the beautiful insight on cardiac MRI. We can see that CMR or cardiac MRI is a very powerful tool in investigating cardiac pathology due to its ability to show tissue characterization. So Prof. Iliseto had just show us that with a cardiac MRI, we can easily see any perfusion that might defect that may be caused by the certain amount of fibrosis in the myocardium, and by looking from the uh, delay enhancement, we can see where the scar is, and that will lead to prognosis of the patient. I believe Prof. Iliseto will have one more talk on advances in the evaluation of ischemic heart disease, the role of cardiac CT and cardiac MRI. If you're ready, Prof.
Yeah, I'm ready. Are
Okay.
the slides projected? Yeah, do you see my slides?
Yeah, we can see
Ah,
it clearly.
okay, so we have spent time in the last talk in understanding which is the potential of cardiac MRI in the context of hypertrophy and heart failure. So the chapter of ischemic heart disease obviously is a tremendously important one, in which, for the reason that I've explained to you before, the potential of tissue exploration, the view of cardiac MRI becomes even more important, much more important, as you will see in a moment. However, ischemic heart disease is the object of potential exploration also by cardiac CT. And I shall give you in the second part of my talk, at the end of my talk, the view of new potential of cardiac CT that, in my opinion, will change the paradigm of the diagnostic approach to the patient with suspected coronary artery disease. So let's start with cardiac MRI. Cardiac MRI has a potential in, for example, in the two extreme of ischemic heart disease. It's impossible to treat all the form of ischemic heart disease, but the two extreme, in my opinion, are acute myocardial infarction, that is occlusion of coronary artery and a disaster that occur in the myocardium, or Takotsubo syndrome, that means temporary impairment of contractility in the absence of coronary artery disease. So let's see which is the potential of all these. Cardiac MRI in acute myocardial infarction has been the object of an increasing interest in the last 10 years. And for those that are interested in understanding, to have an overview of this potential, I think that this paper that was published 10 years ago by my group in cooperation with Professor Joao Lima from NIH in the United States is still a good guide that give you a good overview, a good review of the potential. So I think that cardiac MRI gives us the possibility nowadays to follow the pathologic alteration that occur during time in patients with ischemic heart disease in the context of acute myocardial infarction. So all these steps that are the steps that occur in few hours, upper part, or in months, lower part, were not explored at all until a few years ago. Nowadays, we can understand where we are, what has happened in this catastrophic sequence of events. And thanks to this exploration, we can not only better understand, we can better treat, we can better stratify. So what I want to do now is to show you the potential of this pathology in vivo, because the concept is cardiac pathology in vivo, in the sequence of event of acute myocardial infarction. So let's start from prolonged ischemia. Ischemia means no blood at all to myocardium. Ischemia comes as a term from the Greek, ancient Greek, isko-aima. Isko-aima means I blocked blood flow, so a very good term. And the first sign of ischemia is edema. Edema is the first sign of ischemia everywhere in the body. Think about brain edema. And the potential of cardiac MRI in detecting edema is enormous. This is a two-chamber view of a patient with recent acute myocardial infarction. In this special sequence, again, I remind you that sequence is a setting of those that perform the exam that enhance some structural alteration. In this context, the sequence is designed in order to maximize the depiction of water edema. And in this sequence, blood is black, muscle is gray, and water is white. And you can see that is in this two-chamber view, there is a lot of white, a lot of water. So the question is, okay, but if you are able to identify the presence of edema to water, what does it mean? For what is useful? There is a diagnostic, a mechanical, and an electrical implication. The diagnostic implication is here outlined, and this is an experimental study in which temporary occlusion of a coronary artery was performed in order to produce ischemia. And then in this same study, it was showed that the extent of ischemia here, detected by edema, correlate very well with the extent of ischemia as identified by pathology exploration. So edema can be used to detect the extent of ischemia. And this is important in the context of acute myocardial infarction because we have the aim to salvage myocardium, and the entity of ischemia is a tracer of the entity of the muscle that suffer during coronary occlusion. And so we can understand how much of the suffering myocardium is being salvaged by, for example, thrombolysis or PTCA, because edema lasts for many days. And lasting for many days, it has mechanical implication, as I show you in this nice example. So this is, in my opinion, very, very, very interesting, because we have on the left a patient in the acute phase of myocardial infarction. On the right, the same patient 10, 15 days after. In the upper panel on the left, you will see there is a considerable impairment of contractility of the mid and distal part of the interventricular septum, of the apex, and the lateral wall. While there is a very good contractility here in the basal part, and also a mitral regurgitation, an ischemic mitral regurgitation. Everything disappeared 10 days later. The contractility is extremely good, extremely good. And what we can observe below is the presence of edema that in the acute phase is very important, white. It disappeared in the late phase. So meaning that the presence of edema, that is temporary presence because it's reabsorbed during the following days, is a reason for contractility impairment. And this is the reason why sometimes if perfusion is performed very nicely and early, we can have a temporary impairment, the so-called stun myocardium. Stun myocardium is due to water. The third implication is electrical, and we have explored this in Padova, and we have realized that the presence of edema correlates with the negative T wave in the acute phase of myocardial infarction that we all know is a traditional indicator of ischemia, but more precisely is an indicator of presence of water that is produced by ischemia. So edema the detection of edema is helpful to better understand what's going on in the very, very acute phase of myocardial infarction. But then scar develops. And scar develops with the so-called wavefront phenomenon. It progressively increases its thickness in hours. So these three examples show different entity of thickness of myocardium involved by scar. So on the left, we have a very small area, less than 25% of the thickness of myocardium. In the center, we have white that is very clear, but is not full thickness white. On the right, we have full thickness white here at the apex, meaning that the scar has progressively involves myocardium. This has an important mechanical implication because, as you can see, the higher the level of thickness of the myocardium involved, the lower will be the probability of recovery of function over time. And this is obvious because if you have a lot of living myocardium, in other words, zero scar, the probability of recovery is extremely high, while extremely poor if there is a high extent of myocardial thickness involved by scar. But if we go over time, we have discovered that if the occlusion lasts relatively a small amount of time and then reperfusion occurs, we have only edema. If reperfusion is performed after hours, we have the so-called waveform phenomenon. But if reperfusion is performed very late, let's say 10 hours, 12 hours after the obstruction, when myocytes are by definition dead, but still we open an artery, what happens is hemorrhage. This was already described in the past, the so-called hemorrhagic myocardial infarction. But nowadays we find hemorrhage in our patient in which a reperfusion was performed and was obtained late because, for example, late arrival to the hospital. Cardiac MRI has an abnormal potential. This is a cardiac MRI in vivo, and you can see that what is present is white, and with this white island of black that corresponds to this hemorrhage detected at autoptic table and here by histology. So cardiac MRI is capable to identify the presence of hemorrhage, and I don't go into the detail to how, because we are cardiologists, we are interested in understanding what does it imply, what does it mean. Cardiac hemorrhage, as you will see in a moment, has important mechanical implications. And these are produced by late reperfusion. The implication of all this sequence are mechanical, and mechanical means that we can have a temporary impairment, as I showed you before. This is an implication of this sequence of event. Of course, this is a very favorable implication, but implication can be also this one, in which you have here white, that is scar, then gray. But if you go from this to the movement, you will see that all this contracts properly, but here where there is the white, it does not contract, not surprisingly, because this is scar. So in this sequence of event, the implication on late observation are very important, because from what you observe early, you are able to predict what will occur late in time in terms of mechanical recovery. You can have an excellent mechanical recovery if the reason of lack of contractility is edema. It will last a few days. You will have a bad recovery if the reason of lack of contractility is scar, because edema will be reabsorbed. Scar will remain forever. But the most important implication of what happens in the few early hours is remodeling. And now I show you an extreme case of remodeling. Is a remodeling, unfavorable remodeling in a patient with myocardial hemorrhage. As I told you, hemorrhage can be detected. In this image on the left, you have that is a two-chamber view. White is the blood, and blood in this sequence is depicted in white. Black is normal myocardium, but here you have a large white extent that is scar, and this white extent you have black that is hemorrhage. So not surprisingly, in this case, we have really bad contractility. But we are, in the few days after acute myocardial infarction, these are cases that because of this completely lost of myocyte, also loss of fibrosis, but presence of hemorrhage that is more prone to dilate and to have extension, the propensity to very bad remodeling is obvious. And this is a case of very bad remodeling is not the case that I show you, is an autoptic case in which you can see that is a two-chamber view. You have a very, very thin myocardium in anterior wall. Everything is extended. Here you have the thin myocardium. Here you have a good myocardium, like in the case before, exactly like in the case before. is not the same case, but is unbelievable similar. You have good myocardium, good contractility, huge hemorrhage, poor contractility. And here you have very thin myocardium and a big thrombus within it. Another possibility is to understand which are the cases that are prone, unfortunately, to cardiac rupture, as in this rare case of our series. This was almost 20 years ago, because we started to perform cardiac MRI in the early 20, more than 20 years ago. And you have here white, this is a short axis, white is blood, gray is myocardium, black is hemorrhage and blood. And so you can see that here there is hemorrhage, is a good ventricle, is not large, is a small ventricle, but unfortunately, here we have hemorrhage, and hemorrhage goes through the epicardium, and this is impeding rupture. We realized that this myocardium was going to be ruptured, and on the right you have, unfortunately, because the patient died, the rupture in the myocardium due to the fact that the hemorrhage had involved this piece of thin piece of the myocardium. So there are many implications for hemorrhage, but I think that one of the most important one is here depicted in this very old slide. These old slides come from the GC trial, the first trial on thrombolysis that was performed in Italy. And at that time, the time window to perform thrombolysis was 12 hours. And I think that this is very important in a country in which there are a lot of islands like Indonesia, where of course PTCA cannot be performed everywhere, but thrombolysis is the important tool. And as you can see, this is the risk of mortality for cardiac rupture according to the time of treatment with thrombolysis if compared to the placebo group. And you will see that while if thrombolysis was performed in the group of patients with less than 3 hours, the risk was less of 1%. But when thrombolysis was performed late, 10, 12 hours, the risk was 3 times greater, 2%. And in my opinion, this is due to the fact that if thrombolysis is performed when hemorrhage is present in the myocardium, like in this case that I show you here, the risk of cardiac rupture will increase tremendously. So thrombolysis should not be performed after time window, because the possibility to salvage myocardium will be extremely poor and low, while the risk of cardiac rupture will be extremely high. The other late implication of what happens in the few hours is the electric substrate. So I've shown you that scar is an important predictor of arrhythmias in hypertrophy, in dilated cardiomyopathy, as I showed you before. Of course, these also apply very strongly to acute myocardial infarction, because scar is the result of acute myocardial infarction, is a very common finding, is the typical finding. And if we have an area such as this one, in which there is a mixture of infarcted myocardium, good myocardium, and mixed myocardium and scar, then the risk of area producing arrhythmia is very high. And this is the distinction of the risk of arrhythmias in patients with acute myocardial infarction, with previous myocardial infarction. You can see that if this gray zone, that is a mixture of tissue, is smaller than a certain size or bigger than a certain size, the risk of arrhythmias will change dramatically. As I told you, the other extreme of cardiac MRI in terms of exploration is Takotsubo. I shall not go into detail of Takotsubo, but we understood that the meaning of dynamic type T-wave inversion that is typical in Takotsubo that is characterized by chest pain, normal coronary arteries, giant negativity wave, a contractility impairment. So the link between T wave and contractility impairment is myocardial edema. These are example of tracing obtained in Takotsubo, negativity wave, negativity wave, negativity wave, and recovery over time. But the key element, as you can see here, is edema, here edema that disappear, here is edema that disappear, and here is the tracing before and after resolution of edema. So edema is the key factor for contractility impairment and negativity wave in Takotsubo. And we have understood these things only through cardiac MRI. The last few slides will be devoted, in order to be in the 20 minutes allotted to me, will be devoted to cardiac CT. Cardiac CT has been used for years for detecting the presence of absence of coronary stenosis. And this has been more and more the object of attention, especially because of the big improvement of the quality of the CT scanner that are nowadays available. But the big potential of cardiac CT is not detection of coronary stenosis in order to take decision on what to do. But the big potential is prognosis stratification. These slides show the difference in outcome among patients that were randomized to standard care or standard care plus CT. And as you can see, the outcome at a distance is decidedly different, being much better for those that were submitted to CT. Of course, CT is not therapy, is not something that is good for the health, but it implies that performing CT very likely optimize the strategy, the choice, and because of this, to transform this in a benefit, in considerable benefit for the patient. But in my opinion, and these are the last slides, the biggest potential of CT is around the corner. And these are data that comes from very sophisticated recent research. This comes from the Boston group. We are performing similar research in Padova. And these are new exploration, is the exploration of the pericoronary artery fat. And it has been shown that if the pericoronary artery fat is the object of inflammation, regardless of the present absence of coronary stenosis, the prognosis is different. This is unbelievably important because it is the most powerful risk stratification that we can do independently from blood tests. These are patients with suspected coronary artery disease, and you can see which is the all-case cause mortality in a considerable follow-up, divided the patient in two groups, those that had no inflammation in the pericoronary fat and those that had inflammation in the pericoronary fat. So this discrimination between the two groups is extremely powerful, meaning that the detection of inflammation is a powerful indicator of risk of future cardiovascular event. But this is not surprising because we have learned in this year that inflammation is the key element for developing ischemic heart disease, instability of lung. We have learned a lot of concept about inflammation. The problem was that we were not able to detect inflammation in coronary arteries. Nowadays, we can do this through CT. So in my opinion, the future of CT will be prognosis stratification and identification of patients of higher risk of a poor outcome, and because of this, more prone and more tendency to be more aggressive in terms of prevention, both from the therapeutic lifestyle point of view. So in conclusion, I think that in ischemic heart disease, both cardiac MRI and CT opens new windows, not only for better understanding, but also for prognosis stratification. And again, in my opinion, this will change the future of cardiology in this context, because thanks to CT, we shall be able to identify the patients that are high risk of developing ischemic heart disease independently from the presence absence of traditional risk factor as detected by blood test, because a risk factor in the blood test has a negative effect because it can produce inflammation, but we want to detect inflammation. Inflammation can be detected by CT. Cardiac MRI, again, because it identified tissue alteration in the myocardium that can be the reason for poor evolution, poor prognosis, or mechanical alteration. So these two tools will change our approach to ischemic heart disease, in my opinion. Thank you very much for the attention again.
Thank you very much, Professor Iliseto. Again, a very enjoyable and beautiful presentation. And we can see that with the powerful MRI, we can see that the process of ischemia starting from the very beginning until the very late, from the edema, hemorrhagia, microvascular obstruction until the scar formation, and that would lead to any consequences that it may take, like viability and arrhythmia consequences. And the other interesting thing is the another modality, cardiac CT, that has gone beyond, way beyond anatomical imaging. We can see that cardiac CT will show the prognosis evaluation, and interestingly, it will detect coronary inflammation, and that will give us a different insight for a patient. And I think this all will lead to a conclusion that cardiac imaging as a subspecialty training is very important in cardiovascular study. Um, and I think uh, now we would like to hear another cardiovascular subspecialty, which is echo. And I would like to introduce Dr. Uh, Aryo Surya Kuncoro, cardiologist, fellow of Indonesian Heart Association, fellow of Asian Federation of Cardiology. He will bring up a topic of advances in the treatment evaluation of hypertension and heart failure, role of echocardiography. Um, Dr. Aryo, could we have the CV, please? Dr. Aryo is a lecturer, Faculty of Medicine, Universitas Indonesia, consultant cardiologist, echocardiography and non-invasive diagnostic division, National Cardiovascular Center Harapan Kita, and he's now secretary for the study program for Department of Cardiology and Vascular Medicine, Universitas Indonesia. Dr. Aryo, if you're ready,
Yep.
time is yours.
Okay, thank you, Dr. Sally. Please, host, please let me, can you just let me able to share my screen? Already? Okay. Yeah, yeah. Okay. So thank you for the introduction, Dr. Sally, and greetings to Professor Lizeto. Good morning. So it's a privilege for me to be able to have the same stage with you in this webinar. And also thank you to Head of Department, Dr. Renan, for inviting me to give a talk about this role of echo in hypertension and heart failure. I think Professor Alisato, I think your presentations about the role of CT and MRI in the heart failure is very enlightening. And I will speak about the role of echo, which is we all know that as Professor Alisato has already mentioned, that this is a modalities which more feasible to do and probably more widely used compared to CT scan and MRI. although we all know that echo probably have limitations and drawbacks probably, but there are use of the echo in the clinical practice. So I will speak about the role of echo in hypertension and heart failure. So I have nothing to disclose. So this is outline on my slide. So I will speak about the just a little bit of diagnosing heart failure from the echocardiography standpoint, and we look at the how the process for hypertension for having remodeling to heart failure, which is all related to the advanced process of left ventricle dysfunction going into heart failure. And we have to speak about the, I will speak about the echocardiography in HFpEF and also reduced ejection fraction, and then going on to the deformation imaging, looking from the echo. So I will try to finish my talk in 20 minutes. So here is the, I think here there is the number. We all know that hypertension and heart failure is a common disease which we find in clinical practice, and hypertension is probably the most common diagnosis in our clinical practice. And also heart failure is one of the common cardiovascular disease uh, in populations, in global populations, and also one of the reasons of leading for death. So this is no doubt about it. And raised BP is currently still remain the leading cause of death globally. And awareness of raised BP in the community is very important. And this is why that the this topic is pronounced in this webinar. So because we're going to talk about the role of echo for early diagnosis and awareness for the and organ damage of the myocardium during the process of hypertension. And this is already mentioned that echo is the most common diagnosis tools for detecting etiology, also prognosis, and also to direct our management. If we look at the heart failure, so we see that there are terminology and classifications that we need to be aware of. The first is currently is heart failure is divided into several classifications based on the ejection fractions. The ejection fraction is calculations on result of calculation from the echo and also from other tools like MRI and maybe CT. And this is ejection fraction is a to define the systolic function. It is widely used and has been used for a very long time. And because this is widely used, so therefore it is currently used in a lot of trials and guidelines to classify heart failure. So basically heart failure will be classified into three: those with a preserved ejection fraction, which is considered normal ejection fraction, but with the sign and symptoms of heart failure, and those with a reduced ejection fraction, with also with the sign and symptoms in heart failure, and those with the in between preserve and reduce called the mid ejection fraction. So we call it HF, MAF. So we look at here that the classification based on ejection fraction, where reduce is considered reduced when the ejection fraction less than 40, and then preserve, consider preserve when the ejection fraction more than 50%. There are other classifications and terminology which we should also realize and be aware of it. Is the classification of heart failure based on stage. There's A, B, C, and D. And we look at the heart failure of stage B. We look at that there are structural heart disorders, but there is no symptoms or sign of heart failure at this stage to some extent. And we believe that the imaging is should be able to pick up this stage to prevent the patient to fall into the later stages, which could be deleterious. This I already mentioned that the ejection fraction is very well-known parameters, and it is related, it's believed that related to LV function or systolic function, although there are plenty of drawbacks in this, which is where ejection fraction is impact by the load dependent and also impact to the means of tools for to measure it. So in terms of echocardiography, the ejection fraction is its result of calculation where we imagine that the left ventricle is more like cube. So we call it the volumetric method. Or we can use the modified Simpson method for using echocardiography. And currently the use of 3D in measuring the volume of ventricle during systole and diastole, it is advisable over 2D whenever it is available in the center. So because it will give us the correct measurements of volume of ventricle during systole and diastole, and hopefully it will give us the correct measurement of ejection fraction as well. So at the right side of this slide, just to give you I'm going to give you assignments for the big studies or trials which use ejection fraction to give a sign of prognostic for a patient with the heart failure. So when we're talking about the heart failure, and there are many ways of diagnosing and how to actually look at this patient in the clinic. So there are many history taking measurement and physical exam, and also simple exam like EKG and also X-ray. And this is recommended. Transthoracic echo is recommended in terms of patient of heart failure or suspected of heart failure in order to give information about the function and also give us at least a clue of the etiology of the heart failure. And there are parameters of this echocardiography to give information in patient with heart failure or suspected heart failure. There are information which can gather such as from geometric standpoint, hemodynamic standpoint, and also which is recently there is a modalities from echo which called deformational imaging, which I will explain later. And if we look at the etiology of heart failure, we all know there are many etiologies. Commonly, common etiologies such coronary artery disease, hypertension, or valvular heart disease, or cardiomyopathy. And there are other less common etiology for heart failure, which echocardiography be able to at least give us the sign or clue for us to understand the etiology for give us direction for the management. If we're talking for I will start from the hypertension first. If we talk to hypertension, we know that those with a raised BP, long-standing raised BP or long-standing hypertension will go into the cardiac remodeling. And this cardiac remodeling is in turns, if the blood pressure is not controlled well, so it will be deleterious and will be related to the or will be correlates to the cardiovascular outcome. So the early diagnosis and early awareness of this will give us the direction of how to actually manage the patient with hypertension. So this I quote from the latest guideline of International Society of Hypertension 2020, and again stress the use of echocardiography to detect the hypertension mediated organ damage, which in hypertensive patients will give us the idea of the risk for the cardiovascular disease. So those with a high cardiovascular risk will drive us to give more persistent and more proper management, such as the not only the lifestyle modification, but also gives the pharmacologic medications. And this is where the echo is really helpful, where the echo should be able to detect the evidence for left ventricle hypertrophy, LA dimensions, and also to assess left ventricle systolic and diastolic function. Speaking about the uh, evidence for left ventricular hypertrophy, based on the guidelines of this American Society of Echo and also for European Society, we can see that the echo should define the left ventricular hypertrophy in these classifications. And using the 2D parameters, we are able to measure or classify the left ventricular mass or left ventricular mass index and using relative wall thickness. And then we will be able to define, so if the hypertrophy is either concentric, eccentric, or it's concentric remodeling. And this is from this guideline is already mentioned about the use of assessment for left ventricular mass index using 3D. Although I'm sure this is not widely used yet, maybe because of many reasons. One among others is that to measure the left ventricular mass to define the left ventricular hypertrophy, so we have to be able to get a good 2D image. So for us to see the borderline of the myocardium, so for us to get the proper calculations, that it is where the CMR is much superior than echocardiography. However, if you have the 3D echo modalities, so using the 3D or 4D for the assessment of ventricular mass is advisable. And there is also guidance for the cutoff points. And why left ventricular hypertrophy is important? So we all know that when the myocardium is hypertrophy, is related to the risk of sudden death and also related to the risk for heart failure. So we can see here, at least this is from Framingham Heart Study, you can see that the more thick the left ventricle, it is higher the risk for sudden death. So this is why we need to diagnose this left ventricle hypertrophy using left ventricle mass in routine assessment for hypertension using echo. And we all know then when we give anti-hypertension therapy, and there are regression of LV mass or LV mass index, and this is also related to the reduction also of cardiovascular event. So by pathophysiology, so the regression will improve the diastolic filling, will improve autonomic nervous system dysfunction, and also improve coronary reserve, and also improve vascular changes or remodeling in the vascular caused by the hypertensive position or situation. And we all know that the hypertension is when it is not treated well or not treated properly, it will fall into the heart failure in the end. So by process, we can see there is supposed to be a diastolic dysfunction for many of patients with left ventricular hypertrophy, and those with a diastolic dysfunction will fall also into systolic dysfunction through the myocardial infarction, which caused by the endothelial dysfunction from the hypertension. And this subset of patient will fall into heart failure and eventually death. And echo will be able to pick up the diastolic dysfunction, and echo should be able to pick up also the severity of diastolic dysfunction. For us clinician, by define the diastolic dysfunction in hypertensive patients, so we will be able to see that in what stage the patient when the patient come first time to the clinic. So afterwards, we can do the evaluation, and hopefully when we do the when we give management properly, so we will be able to see some improvement from diastolic dysfunction as well. And this is just to give you the idea of there's a newer pathways from hypertension to heart failure. Just to tell you that some patient will go to symptomatic heart failure with normal EF or HFpEF, and some will go first to the myocardial infarction and then goes into heart failure rejection, ejection fraction, and in which eventually goes to death, which I already mentioned earlier. And some, or probably most of the patients with hypertension, when they first come to the clinic, maybe we are seeing them at the stage of B here, where actually there is a myocardial structural dysfunction or changes, but there's no sign and symptoms for heart failure. And this part of patients could go overlooked, and we probably think this as well, the patient is need not be treated uh, aggressively. Usually when we try to treat aggressively when the patient already at stage C or even at stage D. But I believe that when the patient already at the stage C, it might be too late. So in order to detect the early signs of heart failure, so the definition for HFpEF is also very important in the clinic. So nowadays it calls HFpEF, but earlier it was called diastolic heart failure. First described in 1980, and in a group of patients with sign of heart failure and ejection fraction is more than 50%. And now we all know this is a very important classification or group of patients in which the mortality rate is as high as those with heart failure with reduced ejection fraction. Earlier, there are plenty of modalities from echo that can be used to diagnose, but there are no clear guidance at that time. So which modalities from the echocardiography that can be used to diagnose the HFpEF? But recently, there's a guideline from Heart Failure Association that the use of echo is as a initial steps in the workup of this patient with suspected of heart failure with preserved ejection fraction. You can see here as a echo here has a position in an initial workup as a step 1, and then comprehensive echocardiography measurements in step 2. And then there's still also a place for echo when we still not able to clearly define HFpEF using the diastolic stress test, which is more advanced assessment. And then the others is when we are looking for the etiology of the condition, then we probably need to go to the other imaging modalities. So the modalities from the role of echo in this first steps of HFpEF is we measure the routinely for chambers of left from the heart, and also from the diastolic function, and look for the sign of increased LV filling pressure. And also others, we need to look at the more comprehensive, more advanced assessment of echo using myocardial deformation assessment, which apparently have a role in this diagnosis for HFpEF. As we can see from this table, there's a role of the GLS here, which is call it deformation imaging, or we call it global longitudinal strain, with a value of less than 16%, is one of the minor point of diagnosing HFpEF. So we can use this score points to diagnose the HFpEF. So for those of you who's not really familiar with strain is a part of myocardial or deformation imaging. So we call it strain imaging, and has a very important role in the diagnosis of to diagnose a subclinical myocardial dysfunction, where the strain here has several entity. Those are global longitudinal strain, global radial strain, and global circumferential strain. Among all three, the one which is very robust is GLS, global longitudinal strain. And the normal values for these global longitudinal strains is considered around 16 to 20%. But generally, this is considered when it is higher than minus 20%, this is considered normal. So it is less than that, so it is considered abnormal. So I will skip this. I think this is more technical. So, but I'm just going to stress out that the strength function is related to heart failure. In those with the hypertension diabetes, when there is an evidence of the subtle or subclinical myocardial dysfunctions, in the end, the patient could go into a fall into a heart failure with preserved ejection fraction. when at this stage, we can probably only see the diastolic problem or diastolic relaxation problem, while the deformation imaging from the echo, in this case, longitudinal function, is already reduced less and less. And this is again the use of this deformation imaging to look at to be able to identify the staging of heart failure, which I point out that the stage B, which is where there's no sign and symptoms of heart failure, but there is already reduction of strain. This is where the point when we need to be more careful with these patients, that patient might fall into the HFpEF or reduction, heart failure or reduced ejection fraction. And this is to show you that the value of global longitudinal strain is related to the cardiovascular event, at least from this study of framing of string study with a follow-up 6 to 7 years. And this is clearly show you that there is association with the circumferential strain and also longitudinal strain to cardiovascular events. And there is also the use of the strain in those with chemotherapy. And we all realize and we all know that some regimen is cardiotoxic related to the left ventricle dysfunction. And based on the guideline in 2014, we can see that there's the purpose of use of global longitudinal strain along with left ventricle ejection fraction to detect the subclinical myocardial dysfunction, to give the direction for proper management, or even when there is evidence of the reduce a significant reduction of left ventricle systolic function, then we probably need to stop the chemotherapy. So this is, I think this is very important step where we can use the global longitudinal strain in our daily clinical practice. However, there are strengths and limitations. The strength is strain is superior in prediction of cause mortality, which I already mentioned, and reproducible when performed by trained operators, but there are limitations as well. So I think the one that I need to point out is when vendor and software specific, because there is inter-vendor variability, which we need to remember when we try to measure the strain. And also another thing, this is the few of my last slides, that the use of echo in the assessment for desynchrony. So echo was used for detection for desynchrony before the CRT implantations and for the lead placement during the procedures, and also for the assessment for desynchrony after the implantation of CRT. However, based on the guidelines, we can see that the indications for implanting CRT is not by the echo nowadays, but only based on the ejection fraction, less than 35%, and by the KRS duration is more than 12. And I think the use of echo in these matters is when we need to do a lead positioning and also assessment of the desynchrony after the placement of CRT in patients with heart failure with the CRT implantation. So this is my last slide. I hope this can wrap up my talk, that we see that the use of echo is to define the phenotype of heart failure. And we see that some modalities or some values from the echo measurements is related to prognostic assessment. And there are other markers for prognosis as well. So those like functional MR, which I don't discuss in this due to time constraint. And this is already discussed about the left ventricle synchrony. And there are other new parameters like intracardiac flow mapping, which I don't discuss because I believe this is still in the field of research. So I think that's all I can present it. So I hope this will give us the idea of how we can use echo in patients with hypertension and heart failure. So thank you very much. Thank you for listening. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Aryo, for the beautiful presentation. And as we already know that ECHO is very established, and we are using ECHO every day to study the patient, and we, especially in cases of heart hypertension and heart failure. So, and you already stated that ECHO may help, and beyond our daily routine, it may help for us cardiologists to put into consideration whether the patient need another step forward like CRT implementation. And you already mentioned about the 3D echo in comparison of CMR. So I think this all cardiovascular imaging is really help us in divining the patients. So that is they're not only being tools, a device. So the study is not always about the tools, but how we put that knowledge into patient management, because we are the clinician. And I believe we can go to the next session. It will be very interesting, Professor Eliseto. We will start to go to question and answer, and I can feel the enthusiasm. We got a lot of questions, Professor. So so how are we gonna do this? Okay. So maybe from the very first question, Professor Iliseto, um, Dr. Rudi Anwar Taruli, and he asked about the gadolinium. Is there any cutoff point of uh, glomerular filtration rate to do the study of MR with gadolinium in renal failure?
No, uh, thanks for the question. Is considered nowadays a very safe contrast agent, not comparable to the iodium one. So in even in patients with kidney failure can be used with confidence and with safety. No
Okay.
concern.
Thank you, Prof. So because of the now the gadolinium is more safe, is safer for the patient. Um, I think a lot of question is directed to you, Prof. So maybe another question is regarding the I think Professor Yoga Yuniadi has a interesting question here. He wanted to know, Professor Yoga Yuniadi is a lecturer in our department, and he would like to know if there is a correlation of the QT interval prolongation uh, and non-ischemic epicardial or endocardial scar uh, identified by CMR. Do you have any opinion about that?
So what we have observed is that there is a certain relation between the presence of edema, for example, and QT interval, not exactly for scar, but for edema. So just a small comment. We are learning new things thanks to the exploration of the heart, and I understand the curiosity of my colleague from Indonesia, because there are a lot of curiosity that we are trying to understand. But in any case, QT interval seems to be correlated to edema.
Oh, okay. So it doesn't necessarily about edema. What do you think about the scar? Would it lead to prolongation of the QT interval, and it will eventually lead to arrhythmia? Because I think we got another question about arrhythmia regarding the CMR, Professor.
And the, um, the source of arrhythmia because of the scar is mainly due to abnormal circuits that are created within the myocardium because of the presence of these abnormal myocardium. And this seems to be the major source. For example, one chapter of increasing important interest is the microvalve prolapse. We are understanding that in microvalve prolapse, the source of arrhythmias are to the presence of fibrosis. And this fibrosis is due to the traction of the valve on the myocardium for the prolapse. So independently from the source, the presence of scar produce heterogeneity in the muscle, and this heterogeneity is the source of circuits, abnormal circuits, and the source of arrhythmias.
Okay, thank you. So it doesn't necessarily only in the epicardia, but it could also be from the endocardial.
No, no,
Okay.
not necessarily. If you think, for example, that not necessarily big scar, because what happens in microvalve prolapse is a relatively diffuse fibrosis in
Mhm.
a localized area. So it's the presence of heterogeneity that produce this.
Okay. Okay, thank you, Professor. Um, I think we got a question for Dr. Aryo as well. Um, Dr. Dimas Balti would like to ask if we have data from recommendation, data or recommendation in our uh, national data about population in Asia, eco guidelines, local eco guidelines.
Okay, thank you. I'm glad there's only one question for me, Dr. Sally. So if you yeah, so it's true that most guidelines from European and American, and speaking about the data from the local countries or in the region or our country. So yeah, well, at the moment the big data uh, regarding the echo values, especially like in hypertension, heart failure, for example. So we don't have it yet. So I think there are most what we do have mostly is from data from a single center or yeah, mostly from the single centers. But currently we are in the Eco Society of Indonesia, Indonesian Society of Eco currently is planning to do a big study to give us the values, normal values for from the echo for the normal populations in Indonesia. Hopefully, we'll be able to start the study, and we will give a report of that as soon as it's finished. I think that's all that I can add, Dr. Sally.
Okay, thank you. So I think that will answer the question. So another question for Professor Liseto. Again, a lot of questions directed to you, Professor. So I would group the question into some uh, group. There is in CMR. There's a lot of question regarding the scar. So like this attendee would like to know if there is a way we can differentiate ischemic or non-ischemic scar in diabetic cardiomyopathy. Or another one is when is the ideal time to do CMR evaluation in regards of evaluation of therapy. So maybe you have an answer to that, Professor?
Yeah, usually the position of scar indicates if it's of ischemic or non-ischemic region origin. The ischemic scar starts from endocardium and progress from endocardium to epicardium.
Mm-hmm.
So it can be just a small layer, it can be thicker, it can be full size thickness. But but in any case, starting from endocardium. Uh, all the other scar, those that are in the mid or myocardium, for example, or even epicardium, like those that have been detected in athletes, by definition are not of ischemic origin. So the modality to identify ischemic and non-ischemic origin is simply the position within the myocardium. And again, subendocardium is ischemic, not subendocardium is not ischemic. Then the best moment for observing a patient with acute myocardial infarction should be, in my opinion, after the first days, fifth, sixth, in the first week, but through the end, not only for practical reasons, in order to better treat the patient in terms of facilities, but also because uh, the evolution of the initial part is so fast that we cannot um, take decision, we cannot modify our treatment according to cardiac MRI results because it's extremely fast. It's just a matter of hours. We have performed cardiac MRI early in initial part of our experience for scientific purposes, for better understanding. But now that we have understood the pathophysiology of the first hours, and we have to think not only to science, but especially to patient treatment, I think that after a few days, when the scar is well identified, edema is still present because it gives an idea of the risk area. And if there is hemorrhage, you can detect. You have enough information from the prognostic point of view for the future life of the patient. So I should say around 1 week, 5, 7 days after the acute event. As far as for therapy effect, of course, cardiac MRI is precise, but of course is not feasible on a large scale. What has been done is to use in small series of patients cardiac MRI to detect scientifically the effect of disease, of drug intervention because of the enormous precision of cardiac MRI. But I should not suggest to do this for this purpose because it's not like echocardiography. It's a little bit more complicated, and you need a bigger equipment to do this. I don't think that I don't suggest to use cardiac MRI to detect the effect of drugs. But for prognostic certification, yes.
Okay, thank you, Prof. So we don't usually use CMR to follow the therapy. Um, um,
It,
is there
it would it
uh,
would it would be fantastically useful, but is unfeasible.
yeah? So what do you think, Dr. Aryo? I mean, for doing evaluation of therapy with CMR, it will take because CMR is not readily available, and it will take more effort to do that. So, what about in echo? Do you usually do uh, follow-up therapy with echo?
Yeah, that's a good question, Dr. Sally. It's true that yeah, we do a lot of echo evaluation after treatment or after we diagnose the patient, and we wanted to see the result of our management, and we do, and there's always indications for to do another echo. So as long as it is due in appropriate time, I think there's always indication to do echo evaluations after we do some treatment. For example, then when we have a patient with a acute heart failure or came with a suspected of HFpEF probably, patient with the sign and symptoms of heart failure, and then there's a lot of ankle edema, and then sign also for a lung edema as well, and then the increased BNP. And in this such patient, then we expect that there's in those with a normal ejection fraction, we might find that the diastolic function is reduced, and probably a sign also for increased LV filling pressure. And then after we give treatment, we wanted to see how it goes for the patients, and then we can do the echo evaluation afterwards, and to see is whether there's an improvement on the patient based on the data from the initial echo, and I already show already that there's a use for measuring also the strain, global longitudinal strain, to look at or to give us the supportive evidence that this might be actually there is a myocardial subtle clinical dysfunctions which is related to HFpEF. So I think yes, the question is yes, we can do the echo, and I think we should do an echo when it is really needed for the evaluation after the management.
Okay, thank you, Dr. Aryo. I would agree that echo is for uh, feasible to do for doing follow-up therapy for the patient. Again, Professor Iliseto, we have some interesting question regarding viability, and to what extent that we can tell that the myocardium is still viable, or to what extent that we should just do optimal therapy and not do any intervention because of we think that it is not viable uh, anymore. So we got some question regarding that. Maybe you have opinion about that, Professor.
Viability is certainly one of the biggest potential of cardiac MRI, no doubt.
Mhm.
And for example, for patient undergoing surgery,
Jelas,
when viability issue is crucial, cardiac MRI is extremely useful. And in fact, in our institution, for patient undergoing surgery, we use cardiac MRI when the surgeon wants to have more information regarding viability. For that, the usefulness is enormous, enormous.
Okay, thank you. Um, so with this question, uh, I would like to have a bit of discussion, because with cardiac MRI, we can tell that the myocardium is not viable with the transmodality of like more than 75%. And in your opinion, if you can see that we got left ventricle with a lot of scar, um, would you give suggestion to the surgeon if the patient would go to surgery? Would you give a suggestion to the surgeon not to do surgery for the patient? Maybe better to do just put a stent. So because the myocardium is so thin, so when the surgeon do surgery, it would actually end up hurting the myocardium, and the patient will end up having a lot of bleeding, and he may die in the table. So what do you think about that?
No, again, the viability issue is a fundamental point for revascularization.
Mm-hmm.
It makes no sense to revascularize a tissue that is already dead, because if it's dead, it's dead. So the big issue is how much the muscle has to be viable in order to hypothesize a recovery. Usually, it is commonly believed that if the thickness of scar within a piece of myocardium exceeds 25%, then the possibility of recovery become progressively lower. So a transmural extent is, without any doubt, no chance of recovery, while a transmural extent of scar that is less than 50%, so maximum 30-40%, should have a chance of recovery. So the important point is to measure the entity of scar within the myocardium, and as I show you, is something that is decreasing as a chance. The greater the extent, the lower the probability. So I think that a surgeon that wants to make a good operation, and to balance the risk of the operation with a good possibility of recovery, should take into account this potential, and of course to take care about the data.
Thank you. So, Dr. Arya, in your opinion, if we don't have cardiac MR in our center, so what would you suggest the cardiologist to do to find out about the viability of the myocardium?
Okay. It's a tricky question, I think. So if we are dealing with the stable patients, then we can send the patients for the bitumen stress echo. I think I think it's quite robust modality to look at the viability. And also we can also add the strain in during our measurement of the bitumen stress echo. So I do believe that there are plenty of studies and trials correlates the value of strains for the myocardial fibrosis. And there are also reports about the association of value of a strain which is less than 7, if I'm not mistaken, 7%, which related to the scar. So I think we can use that if a patient is feasible to do the stress echo. Uh, yeah, I think that's also there's also modalities when we can do contrast echo maybe to look at the viability of a myocardium. But if it is available, of course, so currently it's not available in Indonesia. So I think those are the modalities that we can use from the echo to detect the scar, Dr. Sally. And also the very simple presentation of scar from the 2D. We can look at when the myocardium is thin and there's hyperdense of the myocardium fiber, and then we can see that that's related to the scar formation already. That's my
Thank you,
answer.
Dr. Aryo. It will be very helpful for our colleague in peripheral area that don't have CMR facilities. So, in your opinion, is it possible to see any kind of scar in the myocardium using echo?
Yeah, definitely. When there's a thinning of the fiber when the thickness is less than 5, and there's a hyperdense in that area, and also the mobility is very reduced, usually it's akinetic or dyskinetic. So that's correlates with scar formations.
Okay, okay, thank you. So, again, to Professor Eliseto, regarding the patients with hypertrophic cardiomyopathy, um, that have risk of arrhythmia, of course, and this Dr. Pangeran would like to know if should we perform MRI in all patients with suspected HEM, hypertrophic cardiomyopathy. Well, I'm learning this MRI, and to my opinion, at the end of the day, I would love to see all patients get CMR actually, because that uh, with that I can see what happened in the myocardium. But I would like to have your opinion on this.
Hypertrophic cardiomyopathy is without any doubt an important chapter of the strategic approach of cardiac MRI, for the simple reason that we can identify those patients that, because of the present extent of scar, are at particular risk of sudden cardiac death.
Mm-hmm.
So it has been shown that if there is a large extent of scar, and of course presence of arrhythmias, the possibility of having a poor outcome is relatively high. So no doubt that is one of the contexts in which the understanding of the tissue can make a difference for the life of the patient. And again, since cardiac MRI, since hypertrophic cardiomyopathy is not an extremely diffuse disease like it was mentioned by the other speaker, so like hypertrophy in hypertension, particular attention could be devoted to hypertrophic patients, a patient with hypertrophic cardiomyopathy, especially if they have a familiar presence of the disease and they have arrhythmia. So to understand if there are particular risk is crucial.
Okay, thank you.
And we
So,
can do that. We can do that because it's a small group of patients. It's a group of patients of small dimension.
yeah, I will agree. Um, Thank you for the explanation, Professor. And we got this interesting question from Dr. Lie Mena, and he would like to know regarding the further intervention for cardiac issues. He would like to know which one is more benefit to this patient with needing intervention among the FFRCT, CT perfusion, or cardiac MR versus the nuclear imaging, because we know that now the CMR is advanced. So uh, what is the position of CMR, FFRCT, and CT perfusion imaging in terms of further intervention for the patient with ischemic heart disease?
This is a very important question,
Mhm,
and I think that we need to understand what we want to do with that patient,
mhm,
because so we have not even know nowadays the data from the ischemia trial that show us that, with the exception of patient with proximal disease of the left anterior descending artery of left main, to treat or not to treat with angioplasty patient with stable coronary artery disease does not affect prognosis. So the big tendency, in my opinion, this is my personal opinion, and then I give an answer. So before that, the answer to which is the best, um, and I can anticipate that no doubt that cardiac MRI is better in detecting perfusion problems because of the high resolution. Um, Scintigraphy, myocardial scintigraphy has a poor resolution. You will never be able to understand if the ischemic area is subendocardial or full thickness, and this can make a difference. If you think, for example, that in the X syndrome, ischemia is subendocardial, there is a subendocardial layer that is detected by cardiac MRI, is not detected at all by perfusion. But this is, the technical aspect. Then there is the strategic aspect. And I think that in the future, that will be a future more and more difficult from the health management point of view for the well-known pandemic crisis. Um, we have to think when is necessary to understand if there is ischemia induced in a patient with known coronary artery disease. Because if we trust in the ischemia trial results, we have to think that not necessarily correction of stenosis
mhm,
is a benefit for the patient with stable coronary artery disease, because that trial states that in the outcome there is no difference between those treated and those not treated. So if this is the final result of the management, then we have to think when it's necessary to understand precisely if there is or not ischemia, if this knowledge does not affect our behavior. But this is a strategy, is philosophy of medicine. But the answer in terms of technology is I should prefer cardiac MRI to perfusion.
yeah, thank you, Prof. Very clear explanation. Uh, Maybe we got the last question for Dr. Aryo. Um, Dr. Aryo, oh, this he didn't give the name, but he would like to know the parameter of MCF, echo myocardial contraction fraction, yang that is maybe better in determining prognosis in patient with heart failure with preserved ejection fraction, and he would like to know your opinion regarding this.
Yeah, thank you. Just a quick response in this. So we are seeing a lot of parameters, and some are promising in terms of give us a clue about the diagnosis or give us information about the prognostic in HFpEF or those with heart failure with reduction ejection fraction, such as myocardial work and the strain of left atrium and so on. But we have to understand that those parameters has to goes into a lot of trial and studies to look at the reproducibility and the robust of the parameters before it can be used in the clinical practice. So if we look at the small trials or study, we can see there's a plenty of parameters from the echo we can use for to correlate with the outcome the cardiovascular disease, and one of them probably the myocardial fractions, and we have to wait for another reports, so for to see whether that is actually applicable in daily clinical practice. So well, nowadays we are the echo now currently relying on the traditional parameters such as filling pressures to the E per E prime, and so on, and also the currently or only recently that there's a benefit for using the left ventricle strain for detecting myocardial dysfunction, and strain has been present for quite some time, but it takes a lot of studies before it goes into it goes into practice guideline. So I think we need to wait for plenty of reports before seeing that those are actually beneficial markers.
Okay, very interesting. So I think, what about one more question from to Dr. Aryo from Dr. Ansunarta. Dr. Ansunarta is a senior lecturer in our department. She would like to know about the hypertension that leading to heart failure. What about another comorbidities
Yeah,
that leads to left ventricular hypertension? Because hypertension does not usually stand alone.
yeah, thank you. So this is very important question. So we have to realize that hypertension is one of the risk factors for cardiovascular disease, and because of this process in vascular, either macro or microvasculars, and cause the left ventricular dysfunctions. And we have to remember that endothelial dysfunctions cause the coronary stenosis, and could cause patient could fall into a myocardial infarction. If in the end goes into the heart failure, reduced ejection fractions. So yes, hypertension is usually not standalone disease. So we have to remember that there's plenty of comorbid need to be treated in these patients, and the use of echo, just to remind us again that that the left ventricle mass and left ventricle mass index should be routinely used in for assessment for hypertension mediated organ damage, where we can direct our management. And as we can see from the cardiovascular risk assessment, the evidence for the hypertension organ damage, target organ damage, evidence for target organ damage is important for us to direct our management. I think that's my questions. Sorry, my answer.
Thank you, Dr. Aryo, again. ECHO is very useful in our daily practice. And I think we are running out of time, but I would like to, if Dr. Professor Ilseto wouldn't mind, this is one interesting question from Dr. Rudy Anwar Taruli regarding the Takotsubo cardiomyopathy. Uh, he would like to know your experience about this abnormality of myocardium. If it's still, what happens if the ballooning is still present uh, over a period of time, and maybe should we do another study on the patient with this anomaly, with this pathology?
In my experience, in a real Takotsubo, recovery of function will systematically occur. Is just a matter of time. The other point is that recovery parallel reabsorption of edema. Of
Mhm.
course, we can see edema only with cardiac MRI. We cannot perform periodically cardiac MRI to detect the present absence of edema. But we have to make the contrary, following the patient with echocardiography, and then we shall realize that when mechanical recovery has been completed, is highly probable that edema has been disappeared. So what we do is to perform cardiac MRI as early as possible in this small subset of patients, then to see if there is correlation between the extent of edema and extent of contractility impairment, so that we can realize that the contractility impairment is only due to edema and not to small entity of scar, because this theoretically can occur. And then if we see that there is Walmosha abnormalities that corresponds to area of edema, we are confident on the fact that this will recover. And we follow the people over time. And when after 1 month, 2 months, for example, we see that there's been a complete recovery, then we perform cardiac MRI as a follow-up procedure. Then there is an even more simple modality that is to follow T wave, because T wave are another expression of edema. And when edema has been solved, T wave will recover. So at the very end, the reason of all the problems is edema. Unfortunately, we can follow edema only with cardiac MRI, but we can follow the patient very simply with the electrocardiogram and echocardiogram, and then to perform the second cardiac MRI only when, according to echo and electrocardiogram, we suppose that the edema has been resolved, and we want to have the confirmation by cardiac MRI.
Oh, okay, thank you. Very, very clear input to us. So it puts us an understanding that cardiac MRI is powerful tools, but it shouldn't be necessarily do in a routine study, because in here in Indonesia we don't have a lot of centers with cardiac MRI. So to send a patient to the center will take efforts and cost. So now you mentioned about the T wave, and with Dr. Aryo mentioned about the echo, and that would put all the understanding and perspective. So this is a very I think this is a very insightful webinar. But now I think we are running out of time, and I believe that almost every question is answered. Um, by that, um, I would like very much thank you, Professor Eliseto and Dr. Aryo, for sharing the knowledge and give us such valuable insights. And to all attendees for the participation and discussion. And I'm sure that it will help us a lot in our daily practice. I would also say thank you for our sponsor, PT Daria Varia Laboratoria, for all the support, and looking forward for our next exciting session, which I believe a lot to come, and the next series will be held on April the 10th. As I'm wishing everybody success, health, and be healthy always, and please stay safe and have a wonderful weekend. I would like to close this session, but I would give the session back to our head of department, Dr. Renan. Maybe he would like to give some insight. Thank you.
Thank you very much, Professor Eliseto. It's always great, very happy to interact with you. Just continuing some discussion on this, because we are now developing more capabilities on advanced cardiovascular imaging, just like in yours and other places and over the world. We in Indonesia, mostly in our department, we use both MRI, CT, and nuclear perfusion imaging by nuclear scan, technetium imaging, technetium scan. So could you give some brief, what will be the future of cardiovascular imaging modalities in ischemic heart disease, especially whether the cardiac MR will be the leading in this field, or perfusion CT would be also compete in this area, and what's about the nuclear scan itself, and how is it going in Europe? Could we give some brief what will be the future in these subspecialties in this our field?
No, thank you, Dr. Renyan, for this very important question, even because since you're asking a future vision, by definition, it has to be a personal vision, because future is not written, and anyone can think to the future. Then sometimes you are right, sometimes you are wrong. So my vision, my honest vision for the future for cardiology, and this is what I try to transfer to my fellow, is concept number one, the future will be much more clinical than nowadays, because we have to be more able to take decisions, taking the advantage, of course, from the advanced potential, taking decision by ourselves in terms of stratify patients as much as we can on the basis of the clinical approach. So I think this is the rule number one. Then, if you ask me which is my feeling for the future of cardiovascular imaging, I think that CT scanning will be extremely useful for prognosis stratification, for identifying patients that are at risk of developing ischemic heart disease. Because we have understood in the last years that inflammation is the key element for the development of the disease. And if you have a tool that is capable to identify inflammation without using surrogate indicator of inflammation, because all the measurement that we do are related to the possibility that inflammation will develop. We take care about patients that are obese, they don't exercise, they have cholesterol, because we know that these are at higher risk of inflammation and because of this developing ischemic heart disease. But if we can measure that inflammation, then we can identify those that have no traditional risk factor and will have inflammation, or those that even with the risk factor will not have inflammation. And this will explain why among our patients, there are those with a lot of risk factor that do not develop ischemic heart disease, and those that have no risk factor then will develop ischemic heart disease. So I think, again, that an important future will be for CT because it's fast, does not need spatial contrast agent to do things like this. Many patients can be done in a single day, and the information will be prognosis in terms of identify those that needs to be observed more closely in the future. This is my feeling. My feeling is that CT will become particularly important.
Great explanation from Professor Eliseto, and hopefully we can interact more in many fields for the future between our institution, Department of Cardiology, University Indonesia, and Padua University. I look forward for that, Professor Eliseto. Jadi sejawat sekalian, sekedar untuk pengetahuan bahwa di bidang jantung dan pembuluh darah, kita ada 20 tahun terakhir sudah berkembang 8 bidang subspesialisasi ya. Kalau mungkin yang dikenal luas itu intervensi ya, pasang stent itu kardiologi intervensi, ada lagi bidang subspesialisasi aritmia, dan tentu ada 8 bidang spesialisasi, termasuk yang kita diskusikan hari ini yang berkembang pesat, bidang pencitraan kardiovaskuler yang dilakukan oleh seorang kardiologis, seperti Dr. Sally, moderator kita hari ini adalah SPJP subspesialis pencitraan kardiovaskuler. Sedangkan Dr. Aryo dan saya sendiri juga kebetulan adalah subspesialis bidang ekokardiografi. Jadi diskusi ini tentu bukan modalitas mana lebih baik dari yang mana, tetapi semuanya akan berkembang dan bagaimana kita memakainya pada yang mana. Tadi disampaikan bagaimana inflamasi akan lebih terlihat di depan karena kita sekarang berada di era pandemi dan inflamasi sangat penting untuk kita akses dengan modalitas eko, MRI, CT, dan kita juga secara rutin melakukan pemeriksaan nuklir scan di rumah sakit jantung dan pembuluh harapan kita. Saya kira saya akan kembalikan ke Pak Kevin untuk selanjutnya kita menutup acara ini. Thank you. Pak Kevin, please.
Terima kasih, Dr. Renan. Profesor, Dr. and Doctor, could you please to open your camera to take a picture for a moment? Yeah. Okay. Okay, in my count, ready? Okay, 1, 2, 3. Okay, thank you. So, yeah, thank you, Professor Samuel Eliseto, Dr. Aryo, and Dr. Sally, and also Dr. Renan. Baik, sekali lagi saya ucapkan terima kasih kepada seluruh pembicara dan moderator atas presentasinya pada siang hari ini. Semoga apa yang disampaikan oleh para pembicara dapat bermanfaat sehingga dapat memberikan pelayanan yang lebih baik tentunya terhadap pasien. Bapak Ibu Profesor, Dokter dan Dokter, dengan berakhirnya sesi saintifik dan Q&A tadi, maka berakhir pula acara webinar kita pada hari ini. Kami segenap panitia mengucapkan mohon maaf apabila ada kesalahan atau kekurangan pada acara kali ini. Saya Kevin Hernando pamit undur diri dan sampai bertemu kembali di lain kesempatan. Stay safe and healthy Bapak Ibu semua.
Thank you. Thank you.
Thank you
See
very
you,
much.
Professor Iliseto. Bye-bye. Great time. Nice to meet you. Keep safe. Sehat
Thank
semua
you,
teman-teman.
Profesor Iliseto.
Dari sebuah kecintaan akan gagasan, gairahkan semangat untuk bekerja keras. Lahirkan karya bermutu dan berkualitas tinggi. Dari setiap detail inovasi yang dilakukan, yang mampu hidupkan mimpi. Hadir nyata melintasi masa, membentang ke penjuru negeri yang membawa perubahan berarti di dunia farmasi. 1976, Daria Varia resmi didirikan sebagai perusahaan farmasi. 1978, menjadi produsen pertama kapsul gelatin lunak di Indonesia. Dan di 1994, terus berkembang menjadi perusahaan terbuka. 2001, berafiliasi dengan perusahaan farmasi terbesar Filipina, United Laboratories Incorporated. 2012, mencapai angka penjualan sejumlah 1 triliun rupiah. 2016, di usia 40 tahun, Daria Varia tetap berkomitmen untuk Indonesia yang lebih sehat. Daria Varia berdiri teguh di bentang industri farmasi Indonesia. Menghasilkan produk berkualitas melalui 2 manufaktur kelas dunia yang berada di Gunung Putri dan Citerep Bogor. Pabrik Gunung Putri menghasilkan produk kapsul gelatin lunak, cair, krim, dan lotion. Dan pabrik Citerep memproduksi produk injeksi steril dan sediaan padat. Semua produk diproses sesuai cara pembuatan obat yang baik, didukung oleh teknologi yang modern, dan sumber daya manusia yang kompeten, profesional, dan ahli di bidangnya. Pengembangan fasilitas pembuangan limbah merupakan wujud nyata kepedulian kami terhadap lingkungan. Kami sangat memperhatikan kualitas bahan baku, proses produksi, quality control yang ketat untuk memastikan produk yang berkualitas tinggi hingga ke tangan pelanggan. Fokus kepada kepuasan pelanggan menjadikan Daria Varia dipercaya memproduksi produk berbagai perusahaan-perusahaan farmasi lokal maupun multinasional terkemuka dan mengekspor produknya ke berbagai negara di ASEAN dan Timur Tengah. Daria Varia untuk Indonesia yang lebih sehat.
Terima kasih ya.
engkau. Tanah tumpah darahku yang mulia,
yang ku puja sepanjang masa.
Tanah airku aman dan makmur,
Pulau kelapa yang amat subur,
Pulau Melati pujian bangsa sejak dulu kala. Belanda bermain airku Indonesia,
bukan lautan hanya kolam susu, kayu dan jala cukup menghidupimu. Tiada badai, tiada tempat kau temui ikan dan